Hi, my name is Brian Carey, VP of Marketing here at Unbound Medicine. Welcome to today's webinar, where Dr. Paul Nestadt will discuss suicide and the role of gun access in dangerousness risk for psych patients. Dr. Paul Nestadt is an associate professor of psychiatry at the Johns Hopkins Schools of Medicine and Public Health. Dr. Nestadt is a nationally renowned expert on the practical risk factors for suicide, such as firearm and opioid access. He has written dozens of chapters for leading psychiatric and medical textbooks and is the managing editor of the Johns Hopkins Pocket Psychiatry Guide app, of which Unbound is the publisher. Dr. Nestadt will be answering questions live following the presentation, so please type in the chat or Q&A box any questions you have during the presentation. Now I'll turn it over to you, Paul.
Thanks, Brian. I'm happy to be here. I'm going to be talking today about the role of firearms in suicide risk and what we can do about it as clinicians. And this sort of applies to all sorts of lethal means that are used in suicide, but in the United States, firearms do make up the majority of suicide deaths. And so we're going to talk about that in particular. As we go through, I want to first talk about the epidemiology of firearm suicide more broadly and suicide in general. And then I want to talk about the importance of lethal means access in preventing suicide. And then at the end, I want to talk about the use of extreme risk protection orders, which exist in most states in the US. And we'll talk a little bit more about that near the end. And just disclosures, I am funded by the American Foundation for Suicide Prevention. I get funding from the NIH and also from the James Watt Fund for New Disorders Research here at Johns Hopkins. So suicide is a major cause of death in the US. For most of the 21st century, it's been the 10th leading cause of death in the US. In younger age groups, it's even higher ranked. So in Americans under 35, suicide remains the second leading cause of death for young people in America. It's a tremendous cause of death that we need to focus on, especially because it is pretty preventable in many cases. Not every case, but in many cases, we prevent suicide if we do the right sort of assessment and the right sort of interventions. So the suicide rate in the US has been increasing rather steadily throughout the 21st century. It had been high after World War II. Around 1987, which is the year that Prozac hit the market in the US, we started to see suicide rates go down pretty dramatically. And they went down until about the year 2000. And since then, there's been about a 35% increase in the suicide rate in the US. In 2019 and 2020, especially with the pandemic and everything that was tied up into that major pandemic year of 2020, we did see a decrease in suicides, which is a conversation in itself. But the most recent data that just came out here in February of 2023 shows 2021, where the rates have actually started to go up again. And now in 2021, we have almost as high a rate as we have had since World War II. Now, suicide is a behavior. It's an act that emerges from a variety of environmental and personal factors. Some of these are chronic factors and risk factors. Some of them are acute. Importantly, some of these risk factors are fixed and we can't change them, but some are modifiable, so that we can impact as clinicians. So some immutable factors include things like family history of suicide, male sex, white race, having a terminal illness, which by definition we can't change. But other important factors that we can address include social isolation, poverty, access to legal means, which we'll talk about a lot today, and mental illness. Psychiatric disorders remain one of the most significant modifiable risk factors for suicide, which is something that is obviously something we can do something about. We can treat psychiatric illness. Some basic epidemiology, suicide in the US. So the rates are higher in men than in women. This is the suicide rate in men and in women over a long period of time. You can see the rates have consistently been higher in men, such that about 78 or 80% of completed suicides are in men in this country. There's also differences in race and ethnicity. So this figure here looks at race and ethnicity. The blue line here is the white suicide rate over time. The Black and Asian Pacific Islander suicide rates here. The American Indian, indigenous populations have a pretty high rate of suicide. And depending on how the CDC is counting at any given time, either higher or about the same as the white rate of suicide. And interestingly, although there is an increased rate of suicide in white and indigenous populations, it looks different across the lifespan. So this figure here, the solid line, is the suicide rate at different ages in the general population. So you see there's sort of the largest peak around here, around age 50, is a high rate of suicide in the general population, which is predominantly driven by white suicide. Also, if this figure extended, we'd see another spike in the over 85, the sort of barrier, the more old geriatric population. There's another spike. But when we look at this stratified by race and ethnicity, here, this is the suicide rate by age in the indigenous population. We see that it's actually by far the highest in this much younger age group. Indigenous populations have a suicide rate much higher around age 20 or even in the teenage years. And to a lesser degree, that's true also in Black populations here. That's its highest around age 20. So it's a younger high-risk period than we see in the white population. Suicide rates vary by state. We have this sort of suicide belt that's sometimes called. The darker states here, the higher suicide rate. In these sort of the Montana, Idaho, Colorado, Wyoming area. And the rates are lower in these sort of more urban areas, like in New York, California. The more urban states tend to have lower suicide rates. But despite the suicide death rate being so high in this country, one of the leading causes of death, it's still much smaller than the suicide attempt rate. And this is something that's really important to understand, the difference between attempters and suicide completers or fatal suicides. This table here, it divides people by age. So here are youth and adults, so high schoolers. In the past year, high schoolers report having seriously considered suicide quite often. Almost 20% of high schoolers will say that in the past year on surveys, the past year they've seriously considered suicide. 16% have made a plan. About 9% of high schoolers report having attempted suicide in the past year. That's a very high number. And yet only about 11 in 100,000 die by suicide. Those numbers are similar in adults. It's a little less extreme, but still you see 5% seriously considering suicide, 1% making a plan, about 0.6% attempting, but only about 14 per 100,000 dying by suicide. Now, this is something that we can look at in a couple different ways. I like thinking about it this way. We have about 1.5 million adults attempting suicide annually, about 1.5 million each year attempt suicide. About 500,000 are hospitalized for those attempts. So you can think of that as a proxy maybe for the severity or lethality of those attempts, about 500,000. But only about 47 or 48,000 Americans die of suicide each year, a small piece of the overall group of attempters. To understand that difference is where we start to bring in the method used in suicide attempt. Now, it's first worth thinking about the epidemiology of attempt versus completion. And one of the first things that we all learn in medical school about that difference is that women have about 2 or 3 times the suicide attempt rate compared to men. They're attempting suicide much more often. Yet men have 3 or 4 times the suicide death rate. As I said, almost 80% of suicide deaths in this country are male. And when we think about those differences, it makes us look at the methods used in the different sexes. This table over here, it's from Connor in 2019. It's from the Massachusetts group. It's a replication of an earlier study by the CDC. Tends to find the same thing. This is a set of almost 4 million suicide attempts in the US, consecutive attempts. Looking at suicide attempts for 2007 through 2014, just a good large data set. And looked at all these attempts, how many resulted in death. So about 300,000. So about 8% of suicide attempts in the study resulted in death. When we stratify by method, right away you see that by far the most common method of suicide attempt was poisoning. This is overdose, opiates, Tylenol, sleeping pills, all manners of overdose or poisoning make up the majority, more than half of all the attempts. And yet, because only 43,000 of these attempts result in death, we can calculate a percent fatality rate of only about 2%. So in poisoning attempts, only about 2% die, fortunately. The rest go on and get treatment and do well. And we'll talk about what happens to those folks who survive in a little bit. Whereas firearms make up only about 5% of suicide attempts. And yet, because they're so often fatal, about 90% of firearm attempts are fatal, they result in a tremendous proportion, more than half of suicide deaths. Now, one way to think about this is that it might be an explainer for why men have a lower attempt but higher completion rate. Men tend to use guns. Women tend to use poisoning or hanging, suffocation. But men tend to use guns, and so their attempts are much more often fatal. In fact, another way of looking at this is to think about physicians. Especially during the COVID pandemic, there was lots of conversations about physician burnout and physician suicide. In fact, physicians, when you control for demographics, have a lower than average suicide rate. But because we're more male, they tend to be a little bit more fatal. However, the difference is less in physicians. Physicians tend to use poisoning and cutting to a lesser degree as their suicide attempt method. Compared to the general population, they use less guns. So we're talking about male or female physicians. And so the difference shrinks largely because when physicians pursue a poisoning attempt, they have access to more dangerous drugs. They kind of have the knowledge to know what will result in death. And so the fatality rate is much higher in poisoned physicians. And so the gap closes between men and female physicians. It's still a higher rate among men, but the difference is not nearly as large. So when we put this all together, we see that even though about 5 or 6% of suicide attempters do use guns, they become more than half of all suicide deaths. This is 2021 data. Just under 55%, say 54.7% of suicide deaths in this country in 2021, our most recent year of data, were by firearms. In fact, firearms result in death mostly in suicide. The majority of gun deaths in the US are suicides. We talk about mass shootings, we talk about homicide, but about 60% of all firearm deaths in this country are suicide deaths. So there's lots of risk factors. I started alluding to a few of them. A lot of risk factors for suicide, for self-harm. There's genetic factors, personality factors, impulsivity is correlated with suicide attempt. Psychiatric disorder is a major factor. There's also things like experiencing distress, experiencing hopelessness, exposure to suicide in a peer or family member. However, all of these risk factors kind of bottleneck here, come together here, where an attempt is made. And this is where a very important distinction arises. An attempt being made can either result in death, suicide, or in a survived attempt, self-harm. And the only real thing that distinguishes from this point whether someone will become one of those 48,000 Americans who die each year of suicide versus someone who survives an attempt is the method used. If that method is likely to be lethal. Which begs the question, how is a method chosen? And one thing we've learned studying suicide, that the choice of method is largely a consequence of what methods are available to a person, what they have available to them when they have those suicidal thoughts, that impulsive act. To understand that, it's helpful to think about the role of impulsivity in suicide, the proportion of suicides that come quickly after having those thoughts. There's a bunch of different studies that looked at that, but one of the most straightforward and larger studies was done by Simon in 2001. This research group interviewed about 150 young people, these are people under 35, that had made high lethality suicide. These are attempts that were very likely to result in death, but didn't. And they interviewed these 150 some people. And the interview would have gone along the lines of, I know you've been depressed for a while, maybe you've been thinking about suicide, but I don't know how much time passed between the decision to act on those thoughts, that resolving of the ambivalence and the act being decided on, and then the actual act happening. How much time went by between deciding to die by suicide and attempting to die by suicide? And Simon and his team found that fully 87% of these interviewees had only decided to make the attempt within 24 hours of making it. Most of them was within the hour, 71% within the hour. About half of them was less than 20 minutes. And in a quarter of these interviewees, it was in less than 5 minutes. Really, most of them, it's very rapidly that decision to act and then acting. And what that tells us is that if they're acting so quickly, then what they have available to them is what they'll act on. If it's 2 a.m. and the patient makes the decision that they're going to act on the suicidal thought they've been struggling with, and what's in the bedside table is Tylenol or sleeping pills or something like that, and they use that, chances are they'll survive. Remember, only 2% of people that make a suicide attempt by poisoning die in the attempt. But if what they have in the bedside table is a firearm, their chance of survival is much, much less, about 10%. 90% do die in those attempts. And so when we think about who uses a gun for suicide, it really boils down to people who own guns. These two maps are important to look at next to each other. On the left, this is firearm suicide by state. Now, I showed you a similar map with suicide rate by state across all methods. This is specifically firearm suicide, people who use a gun for suicide. It look that different. The dark states have higher rates. Again, it's Wyoming, Montana, Alaska. And if you look over here on the right, it's the proportion of households in each one of these states where there's a gun in the home. So Montana, it's like 52%, Idaho, 57%, Wyoming, 54% of households have guns. And you see these maps look very similar as you look state by state. They're almost identical. Let's look at it a little bit more scientifically. Matt Miller and his team in Boston compared areas of the country that had high gun ownership to areas of the country that had low gun ownership. They used metropolitan statistical areas. These areas with high gun ownership were defined as an average proportion of households with firearms, about 34%. And in this country, low gun ownership meant that about 11% of households in those areas had guns. And Miller and his team compared the suicide rate, the firearm suicide rate, the non-firearm suicide rate, the total suicide rate in these areas to each other, controlling for all the other sorts of things that might affect suicide rate, controlling for things like proportion of veterans, controlling for things like demographics, like race and sex, which I mentioned before, play a large role in suicide risk. Controlling for all the things you'd want to control for. It's one of the skills of that group. And they found that on the whole, firearm suicide was about 2.4 times as common in high gun areas compared to low gun areas. Non-firearm suicide was the same. That just demonstrates how they were adjusting for the right variables, really. So there's no difference in non-firearm suicide. But because so many suicides are by firearm, the total suicide rate in high gun areas was 1.5 times or 50% more than in low gun areas. Miller also stratified by men, women, and children. And I think it's worth paying attention to children in this situation. For kids, here defined as under 18, the firearm suicide rate was 3 times that in high gun areas compared to low gun areas, which meant the total suicide rate was almost double in areas that had high gun ownership. There's been other studies that looked at that. Engelmeyer looked directly at individuals who had access to a firearm as opposed to areas of the country and their rates, and found that individuals with access to a firearm have about 3 times the risk of suicide compared to those who do not have access. There's also a great study by Danielle Steele-Smith and colleagues that found that in urban counties, for each additional gun shop in the county, there's a 1% increase in suicides in that county. There's a couple of ways to look at this. There's a study that looked at youth suicide state by state. I found that, I don't know if you can see this on your screen, but each of these dots is a state. So here's Maryland, where I'm calling from right now. Here's Colorado, here's Hawaii. You see that on the x-axis here is the proportion of gun ownership in those states. And on the y-axis is the log of the youth suicide rate, the overall youth suicide rate. The more guns, the more suicide. This is just a straightforward comparison, but the same team did a multivariate model and found that for every 10% increase in household gun ownership, the youth suicide rate increased by about 27%. It's pretty dramatic. Now, when I talk about the role of firearms in suicide, one of the first things that I often hear from folks is, well, sure, people that have a gun will use a gun, but if they don't have a gun, won't they just find some other way to die by suicide? And this is a commonly held belief. In fact, it's a belief that's been studied by epidemiologists quite extensively. One of the best studies was again from Matt Miller's group, where in 2006, they surveyed Americans, just the general population of Americans, and asked them a hypothetical. They said, if someone had been about to jump off the Golden Gate Bridge, but they've been stopped in some way, they've been thwarted, would they have found some other way to complete suicide? And 74% of Americans, the majority of Americans, said, yeah, most or all of them would have found some other way to complete suicide. It's a commonly held belief. Emmy Betts, who's an ER doctor in Colorado, did that study specifically with ED physicians and nurses. And remember, ER clinicians are the ones making the decision when someone comes in after a suicide attempt or after having suicidal ideation. They're making the decision about whether they're hospitalized or not. So this is an important group. And ER physicians and nurses also, a little more than half of them believed that if a firearm suicide decedent hadn't had a gun, most or all of them would have just completed some other way. It's a commonly held belief. Now, it's a false belief. And there's a reason that Miller's team used the Golden Gate Bridge example, because that's one of the best studied examples of people that had been thwarted from an attempt and what happened to them afterwards. Seiden in the 70s looked in on 515 people who had been going to jump off the Golden Gate Bridge, but were physically restrained or saved during that attempt. So some of these people had jumped off the bridge and survived. It has about a 1% survival rate when you jump off the Golden Gate Bridge. It's generally pretty lethal, but people can survive the fall. They can get caught on the scaffolding. People be pulled off by the police or bystanders. And these folks found 515 jumpers who were stopped. And they followed them for a median period of 26 years. It's a very long follow-up period, the kind of thing we have trouble getting funding for these days. But following them for that long, they found that only about 5% of them ended up completing suicide after surviving that attempt. And the people that did die by suicide afterwards, almost all of them were almost immediately after the unsuccessful attempt, the survived attempt. There was another study in London where O'Donnell found that of 100 people, almost 100 people that jumped in front of the London subway, the tube, they found that of these 100, only about 10% of them, 9.6% of them, went on to reattempt and die over a 10-year follow-up period. There's been meta-analyses of studies like this, and it turns out the number is about 6%. About 6% of people who survive a potentially fatal suicide attempt will go on to die by suicide. The other 94% continue to survive and thrive and do well because suicide is the result often of a treatable illness like depression. So then what happens when you do take a popular, lethal, convenient method of suicide and you remove it? Well, there's been a few natural experiments and a few contrived experiments that have looked at this question. One of the most famous was a natural experiment. In the UK, coal gas ovens were a popular method of suicide throughout much of the 20th century. So these were ovens that were powered by coal gas, and so they would produce carbon monoxide. So someone that was suicidal could blow out the pilot light and put their head in the oven, and then die of carbon monoxide poisoning, which is quite lethal. Many famous suicides like Sylvia Plath used this method. But throughout the 60s and 70s, the carbon monoxide, the coal gas content in ovens was reduced. There was a switchover in the UK from carbon monoxide producing coal gas ovens to natural gas ovens, not to prevent suicide, but for economic reasons. And Kreitman's group followed the suicide rates across the UK, across England, Scotland, and Wales, as these ovens were sort of converted. So this figure on the left is the proportion of ovens that were still coal gas or carbon monoxide producing ovens. You see them coming down until by 1975, the ovens don't work that way. At the same time, look at the suicide rate in men and in women. In men, this is the carbon monoxide, so largely coal gas oven suicide rates, going down as the ovens went down, with no real change in the other sorts of suicide, the non-carbon monoxide suicides. But because so many were carbon monoxide, it was a popular, lethal, convenient method. The total suicide rate in men went down dramatically. In women, it was almost the same thing. Carbon monoxide suicides went down, maybe some replacement with non-carbon monoxide methods, some increase in hanging, but not nearly enough to offset the suicides that were prevented by the lack of ovens, and so the total suicide rate went down. But just to note, there's still some carbon monoxide suicides happening. It doesn't go down to zero. And part of the reason for that is that there's other sources of carbon monoxide. Car exhaust at that time could be used. But to die by car exhaust, you'd have to set up a hose into the car, through the window, tape up the window. It was a process. It was less convenient. And so it wasn't used very much. That's going to be an overarching theme as we talk about methods, is that when there's anything that delays that impulsive move from decision to action, lives are saved. So in Sri Lanka and other agricultural economies, it's a different method. Pesticides and herbicides are often used in suicides because in agricultural economies, they're often available. And pesticides can be very lethal. This figure here looks at the suicide rate in Sri Lanka over time, stratified by method. The light blue line here is poisoning, which is largely pesticide. These other lines are other methods. Here's hanging, a distant second, and then other methods like shooting, cutting, that kind of thing, jumping. You see that the pesticide suicides make up the majority of suicides. Here in 1984, a few pesticides that were carcinogenic were banned, didn't have an effect on suicide. But here, all class 1 pesticides, these are pesticides that are easy to instantly die on, were banned in 95. And the suicide rate by pesticide went down dramatically. Here's one more pesticide banned. Suicide rate continued to drop. And there was maybe a very slight replacement of method, people using hanging slightly more, but nothing that would replace the lives saved by reducing access to pesticides, such that the suicide rate in total was cut almost in half in Sri Lanka and stayed down. Similarly, in the UK, paracetamol, which is Tylenol, essentially, was a common method for suicide. People would overdose on paracetamol. And so there was a very conscious decision made in the UK to make it so that people couldn't get Tylenol, paracetamol in bulk anymore. They made it so that if you go to a pharmacy in the UK, you can only get 16 tablets of paracetamol at once. Anything more than that, it comes in that blister packaging, the kind of the bubble wrap where you got to get your fingernail in to pop the pill out. So that if someone wanted to overdose on paracetamol, they'd have to sit there and pop all these pills out, which doesn't take a terribly long time, but might take 5-6 minutes to pop a bunch of pills out. But that delay was enough that the UK poisoning suicide rates dropped by 22% when they made that change. There's other examples like soldiers in Israel who were dying by suicide largely on weekends when they were bringing their firearms home on the weekends. They changed the policy, it's leave your gun on base, and suicides dropped in this population dramatically. In the US, as I mentioned, it's guns. And so regulations throughout the history of the US that have changed access to guns have resulted consistently in a drop in suicides. When Washington, D.C. started requiring gun licensing, basically putting a barrier between wanting a gun and getting one by requiring a license, firearm suicides dropped by 23% no replacement with other methods. Dan Webster here at Hopkins found that child access prevention laws, these are laws that make it so that if there's a kid in the house, that any gun in the house needs to be stored safely, right, just locked up. Found that when you pass those laws, there's a decrease in suicide rates among teenagers by 8%. Mike and Nestadt and Joy and Nestadt, the husband and wife research team, found that state laws that require guns to be stored, locked, or state laws on background checks or state laws on restricting open carry, any law that put a barrier between wanting a gun and accessing a gun, each law individually decreased suicide rates. And Kaufman, who was a surgery resident when she wrote this paper, looked at a composite score of the stringency of firearm regulations for each state and found the total suicide rate was decreased by 20% if the state just had a more stringent set of gun laws. She also found that homicide rate was decreased by 43%. That's a different topic. So what does this mean for clinical practice? Well, quite a few things. Patients with any level of suicide risk, psych, history of violence, suicidality, dementia, is a major risk factor, should be asked by their doctors about gun access. They should be educated about the dangers. A lot of the statistics that I've given you just now are the sorts of things that can be repeated to patients. Oh, having a gun increases your risk of suicide by 3 times, kind of thing. Suicidal thoughts can come on very impulsively. We'll act on them very quickly. So what you have available matters. Those sort of statistics and facts can help guide patient behavior. So reducing lethal means access should be a core component of any safety plan. And I'm going to talk about safety plans on the next slide. Safety plans are maybe our best tool to prevent suicide. These are an intervention that was sort of popularized and implemented best by Barbara Stanley and Greg Brown. But one key aspect of that is lethal means safety. We'll talk about that in the next slide. Another thing is that there are a variety of interventions and recommendations that we'll talk about in a second that can be made for patients relative to their risk level. So, for instance, at a minimum, it's important to encourage safe storage, right? So if there's a gun in the house, you identify a gun in the house when you ask your patients, recommending that it be stored safely so that kids in the house or other people in the house that shouldn't have access to that gun can't. Also, during a crisis, it might be worth recommending out-of-home storage. We'll talk about those options in a second. Places to keep the gun that is inaccessible even to the gun's owner. There's also something called voluntary do not sell lists. These right now only exist in Utah, Washington, and Virginia. Maryland's about to pass such a law. These are opportunities for patients who are worried that in the future they might be at risk. So someone with bipolar disorder or with recurrent depressive episodes or with dementia can add themselves voluntarily to a list that gets put into the NICS so that if they go to buy a gun in the future, they'll be forbidden from buying a gun because they put themselves on this list, the do not sell list. And then maybe the most extreme intervention is a red flag petition. These have been in the news a lot lately, red flag laws. We'll talk about these laws in a second, but these are laws that essentially make it so that if a family member or the police or a clinician in some states feels that someone's a danger to themselves or others by having a gun, the firearm can be removed involuntarily and they'd be put on that list to not sell a new firearm temporarily. This is an extreme situation we'll talk about in a second. Now, it's important also to note, it's never illegal to ask about gun access. For a while, there was briefly a law in Florida that made it seem like physicians in Florida could be prosecuted for asking about gun access if it wasn't medically relevant. But that law was repealed, and it was always medically relevant for the reasons we just went over. It's relevant for preventing suicide to know if someone has access to a gun, to the point that it might be malpractice not to ask if you have a patient at risk. So I want to talk about safety planning just briefly. A safety plan is something that can be worked out with any suicidal patient. And it consists of a variety of steps. First, asking the patient alongside you or alongside their therapist, come with a list of warning signs personalized for them, things that they recognize as something that indicates a suicidal crisis or suicidal thoughts might be coming. These might be images, moods, situations, behaviors they notice themselves. And then writing down some internal coping strategies, things you can do. So a patient might start with something as simple as, well, when I feel that way, I listen to music, or I take a walk, or I call somebody that makes me feel better or that I can connect to. Which brings us to step 3, which would list people and their phone numbers written right there that can help them. It might be a friend or a sponsor or a family member or a therapist, or a place they can go that's safer, like the ER, for instance. And then they can list people to call for help. They can list professional agencies, but I want to draw your attention to step 6, which is making the environment safe. This is a very important part of a safety plan. When these thoughts are coming, it's important that a patient knows that's a good time to not have access to your firearm or to other lethal means, stockpiles of medication, weaponry, maybe it's not the time to be driving a car, the highway, that kind of thing. Things you can do to make the environment more safe. And with these safety plans, families should be incorporated in, if at all possible. A partner or family member or roommate even be brought in on this plan to help make the environment safe when the patient reports that they're in a crisis. Safety plans are one of the best evidenced ways of preventing suicide. Now, when we talk about safe storage and making firearms less accessible, some of the strategies I mentioned a couple slides ago, there are a variety of options. This is from a table from Meg Ranney paper with Emmy Betts, where Dr. Ranney lists a few options for safe storage, ranging from cable locks, which are very cheap. Here, she lists them as costing $10, $50. In fact, they cost less than that, and you can even get them free. You can get, this is a cable lock that I got for free from the VA in Colorado, the 50 boxes of them. Project Child Safe is a project that works with the police to get patients and clinicians cable locks for free that you can give out in ERs. There's also trigger locks, which cost a little bit more, and they're gun specific. Then there's lock boxes, which cost a little bit more than that. Safes. There's the idea of disassembling a gun using smart guns, which are ones that have biometric identifiers like a fingerprint. And then there's out-of-home storage, which I mentioned earlier. So these are options like having, during a crisis, having the gun stored with a family member or brother-in-law or a trusted friend. The laws around transferring a gun vary from state to state. So you want to know what's happening in your state. Generally, many states have emergency transfer laws that allow you to give someone else your gun in an emergency, like a suicidal crisis, even if they haven't had a background check, that kind of thing. But it's a little gray because, what happens if that gun is stolen from that person or if it's used in a crime, or when does that person give the gun back? But it's something that can be done. You can also store guns with law enforcement or at a gun store. A couple of states, I highlight a couple here, Colorado, New Jersey, Maryland, Mississippi, sorry, that's the wrong abbreviation, and Washington, have safe storage maps. You can go to these websites to see sort of an overlay of places that have agreed to store people's guns for them in a crisis. They're mostly shooting ranges, gun stores, police departments, that kind of thing. And then there's the red flag law, which I alluded to before. Now, these are those laws that, as I said, allow police or family members to petition a court, temporarily remove someone's access to guns, and remove their ability to buy a new gun temporarily. Generally, it's for a year period. The first one of these was in Connecticut back in '99 after a school shooting there. But after the Parkland shooting in 2018, these really took off. And now there are 19 states and the District of Columbia that have some version of a red flag law. In California, it's the gun violence protective orders. In Maryland, it's the extreme risk protective order. And they all work essentially the same way. One unique thing about some of these states, like Maryland, is that in Maryland, DC, Hawaii, Connecticut, and New York, some more that are coming online, clinicians can be the ones to petition, not just family members or the police. And that's important for us clinicians because having that tool means that we have an obligation to use it when we can. These are effective. Jeff Swanson at Duke did a study of Connecticut's version of the law when that was one of the only ones around, and found that in Connecticut, for every 10 or 11 guns seized, one life was saved from firearm suicide. So that's a number needed to treat of about 11. It's pretty good. Aaron Cavisto and Peter Fallon, a year later, used a synthetic control model to estimate Indiana's version of the law. They found that Indiana's version reduced firearm suicide by about 7.5% over 10 years, without any increase in suicides by other means. Gary Wintemute looked at this law in terms of mass shootings. So although, as I mentioned, the majority of gun deaths in this country are suicides, these gun laws tend to be triggered, so to speak, by mass shootings. And these laws have been very successful in preventing mass shootings. Wintemute found that of 159 available URPO records, or red flag service records in California over 2 years, there were 21 instances where the URPO very clearly stopped a mass shooting that was about to happen. So petitioning for an URPO is pretty easy, but it varies from state to state. This is just Maryland's process. I'm just going to leave these here. In Maryland, which is a pretty characteristic state other than allowing clinicians to file, you essentially fill out a short form that you submit to the courts. Now, there's some barriers for clinicians filing even in Maryland, one being that you do have to go to court. So I'm often recommending that people, if their hospitals have a built-in navigator system to file URPOs, that they work with the family or police to be the actual filers. But clinicians can play an important role in filing URPOs in red flag laws, depending on which state you're in. And I'd be happy to answer some questions about that during the Q&A following this. But just to wrap up, Just to summarize, suicide is a leading cause of death in the US. The rates have been rising throughout the 21st century, and yet it is often prevented. It can be an impulsive act. People use what they have available to them. And if they survive the attempt, they do have a chance to get help, and they generally do. 94% of the time, they don't go on to die by suicide. But if what they have available to them is lethal, accessible, they are likely to die in the attempt. In some places, those lethal methods have been coal ovens or poisons or paracetamol. But in the US, the most available and lethal means are guns, which unfortunately have a political valence here. Nonetheless, screening for firearm access, regulating access to firearms, requiring safe storage, generally decreasing firearm prevalence will likely save lives. And in extreme situations, red flag orders or extreme suppression orders can be filed. So thanks. So we have some time for questions. I'm happy to go over. Just want to thank my collaborators at the medical examiner's office here at the Gun Policy Center and around Hopkins and some students. But thank you very much. Hey, everybody.
Hey, Dr. Nestadt. How are you?
I'm wearing a different outfit because I'm pre-recorded, as you guys probably know. But I think, should we just do a Q&A? Is that how you want to?
Yeah, absolutely. One, just want to thank you for your time and your expertise in sharing with everyone today. And I want to thank everyone that logged on to the call and took time, their valuable time out of their busy days to listen and see this. This was absolutely amazing, and I think there were some great stats and really valuable information that can hopefully save some lives. So thank you so much. First question is, my state doesn't have a red flag law. What should I do if my patient is at high risk and has a gun?
Well, that's a really good question. The bottom line is that most states don't have a red flag. As I mentioned in the talk, 19 states in DC have some version of red flag law called different things. I refer to it as an extreme suppression order here, but in California, it's a gun violence protective order, that kind of thing. If you don't have that, there's lots of things you can do. The first thing you can do is have a conversation with your patient. And obviously, this is going to be dependent on the specific case that you have in front of you. So very commonly, before we had a red flag law here in Maryland, so before 2018, this would come up the most in the pediatric ER, where there would be parents that would have guns, and the child would be here for a psychiatric complaint. So we'd have a conversation with the parents about the risks that they face. And that conversation would be a lot like the talk you just heard. Here are some of the numbers. Here are some of the ways that having a gun might put your child at risk. Here's how your child might find the gun, even if you think that they can't, because kids are really good at finding stuff. And so that conversation is one thing you can do. Another thing you can do is that there's other mechanisms that might protect the person from the weapon if it's going to be in the house. The most obvious one, and I talk about this in the talk, is safe storage. So at least you can encourage safe storage of the weapon. If it's, let's say, the gun owner themselves that's at risk, as opposed to someone else in the house, then maybe temporarily during a crisis period, the gun owner's partner, spouse, somebody else could sort of have the keys to the safe, so to speak, or the combination could be changed. Or even better, the gun could be stored outside of the house. I mentioned in the talk that there's places that'll store guns for you in most states, and you can always go to the police for that. In extreme situations where they really are not amenable to sort of interventions and you kind of have to be more paternalistic, your options are more limited, but it's worth talking to the police in your locality, because sometimes there's other ways that a gun can be removed from someone who might be potentially a danger, aside from this very specific method that's designed for it. Those ways, those sorts of emergency transfers are different in every state. And to be honest, they're not as clean and are the kind of things that you kind of really have to have buy-in from somebody, the police department in your locality, or at least family members that will support it, that kind of thing. The other thing is that for psychiatric patients, if you're in most states, if you've been involuntarily hospitalized, or in some states, even if you've been voluntarily psychiatrically hospitalized for more than a certain period, in Maryland's 30 days, then that makes it illegal for you to purchase a gun. Sort of you lose your right to firearm ownership. That's another sort of method, would be if someone was so psychiatrically ill they needed hospitalization, the firearm would be part of that.
Fantastic. Thank you. This next question was it was asked in a couple different ways, but generally speaking, what the COVID pandemic, what impact has had on suicide rates, or really what effect has COVID had, on suicide and in the psychiatric community?
It's complicated. So we all thought that COVID was going to increase suicide. And everyone probably saw the stories when the pandemic was starting about how COVID represented sort of a perfect storm for mental health in general and for suicide specifically, because people were losing their jobs. People were grieving people they lost to the pandemic, were isolated. They couldn't get access to supports like their family, to their church, to their mental health providers. We thought this was going to be a disaster. But then strangely, the COVID year, 2020, that first COVID year, saw a dramatic drop in suicide rates. Actually, the largest drop we'd seen in the 21st century. Suicide rates went down. And there's a couple of reasons. It's a whole other talk about why that might have happened. But unfortunately, first of all, that decrease was not universal. It turns out that certain subpopulations did have an increase. I had a paper that looked at the difference between Black and white suicide rates during that first COVID lockdown period. And while in Maryland, and this was replicated in Connecticut and elsewhere, in Maryland, the white suicide rate was cut in half during the lockdown. The Black suicide rate actually doubled in Maryland, which is a tremendous increase. And usually we talk about suicide rates changing by like 5%, 3%, doubled. So, it was a perfect storm, but we weren't all in the same boat, So there's that. And then in 2021, I mentioned the talk, the rates went up again. So we actually, the last year of data was the largest increase in suicide, 1 year increase in suicide that we've seen since World War II.
That's fascinating. Thank you. I think we have time for one more question. This one's a bit more specific, but if you had a gun-owning patient whose suicidal plan is specifically not about the gun, but they are adamant that if they ever did it, they would overdose or use a different method, would you still prioritize the gun removal?
I would. There's been studies that look at the method used in suicide attempt and in suicide death when we have information on what people were saying they were going to do. So because there's such a strong correlation between psychiatric illness and suicide, then not always, but often people that do die by suicide were in psychiatric care. And so there's notes to go through. And it turns out there's no correlation between the method someone says they're going to use and what they actually use. Someone might be adamant that if they ever go, they're going to hang themselves or they're going to overdose on opiates or whatever. They might have whole reasoning set. Oh, I want it to be painless. I want my body to have an open cast, all kinds of things. But at the end of the day, what studies have shown is that when that suicidal impulse does crest and come quickly, people use whatever is there. So if the plan could have been for years to overdose, maybe they attempted suicide by overdose a dozen times, but survived, as most people do. There's a gun there. That's what will be used in that impulsive period. And so because of that, it's very important that regardless of what someone says, the method they think they will do, whatever their plan is reportedly, you do everything you can to protect them from access to lethal means. That applies the other way too. If someone says, I'm definitely going to use a gun, this doesn't mean like, oh, you get the gun out of the house, you're fine, right? There's lots of other things they can do, not as deadly, but still dangerous. So you want to make sure they're not stockpiling medicines, et cetera. So yeah, I wouldn't want to, feel too confident if you eliminated the method that they have reported they'll use.
Great. Yeah, and we just had one that just came in. I think this is pretty interesting because it's from the physician perspective about themselves. It's, can you talk a little bit or have some strategies to forgive oneself if you missed a cue? So
that's a good question. And that's actually, I have a talk I give on that topic. Because obviously it's a prominent and prevalent one because suicide happens so often. There's a saying in psychiatry that there's two types of psychiatrists, those that have lost a patient to suicide and those that haven't yet, right? Or sometimes they say, or those that don't know that they have. I think unfortunately, because of the nature of the way we provide care, sometimes someone's lost a follow-up, you don't know if that's because they stopped wanting to pay or return your calls or if they died by suicide. You often don't know. In fact, that's how I got into this field. I went to the medical examiner's office after working ER shifts as a resident and was just sort of wanted to check if I was making the right decision. Did any people that I didn't admit end up at the morgue? And that's how I started looking at suicide data through that. So you have to know. But what I would say, and what I do say to our residents, for instance, when this happens, is that, first of all, it's very hard to predict suicide, right? I'm a suicidologist. I've written papers on risk stratification and screening. We're terrible at it. We're terrible at predicting other direct violence too. We're really bad at predicting suicide, even as experts, as psychiatrists. So when you're a physician whose patient dies by suicide or a family member who loses someone to suicide, it's important to recognize that you didn't necessarily miss something. It can be impossible to know. And those thoughts can come on so quickly that even the person themselves might not have known that they were at risk of suicide a day before when you were talking to them. So there's that. The other thing is that it really is a prominent cause of death. I mentioned in this talk, it's the second leading cause of death for Americans under 40. It's very common. We don't talk about it so much, so people are always surprised when they hear that, or surprised when they hear that suicide is more common than homicide. But it's very common, so it happens. It just happens. And for whatever reason, because of the nature of the way we look at mental illness, there's just more stigma and so more guilt to the providers. Cardiologists are obviously upset when they lose a patient to a heart attack, but they also know what's going to happen. It comes with the territory. They're treating people with heart problems. They're going to lose people to heart problems. Psychiatrists are treating people with mental illness that are at risk for suicide. We're going to lose patients to suicide. It's going to happen. And sometimes that helps the provider. Sometimes it doesn't. Sometimes it just takes time. And what helps the most, in my experience, is when you can connect people together who have also lost folks to suicide. And that applies to physicians and clinicians of all sorts, but also for those bereaved by suicide. So the best interventions for suicide bereavement tend to be group-based. The American Foundation for Suicide, the AFSP, American Foundation for Suicide Prevention, puts together groups in localities. You can contact them, and they put together bereavement groups that are specific to this unique type of bereavement. So
excellent. Thank you. I think that's all the time we have for today. Dr. Nestadt, thank you so much. And thank you to everyone that has participated and came to this webinar. There is a survey once you log out. So if you can, this will help us generate future webinars in the topics that you want to hear. So, keep an eye out on your email. We have more webinars that are coming, and just want to wish everyone a wonderful day. And thank you. And I'll talk to everyone very soon. Thank you so much.
Thanks for having me. Thanks, everybody.